board members. Got it. And so maybe one more minute before we get Gardner. It's good to see you. I thought are you down in San Francisco?
No, Gina's leaving next week on Monday. I'm going to stay here. I just had today 6 spinal injections. I have a very bad back. So there were cortisone steroid injections.
Wow. Yeah, that's hard. I want you to know that I just told Joe to give you an excused absence. So Joe, take that back.
Thank you.
Well, I think we do need to get the meeting going. I see 3, 4, 5, 6. Everybody's jumping around. Board members, 7. And Emmy's with us. So I'm going to call the meeting to order. This is the welcome to the monthly Behavioral Health Board meeting. We are the official advisory board for the Board of Supervisors. And we hold this meeting on the 4th Thursday of each month. It runs from 12:15 to 2:15. This is a public meeting and everyone is invited to attend. And we provide time for public comments. And I will say more about that when we come to that time. Please note that this meeting is being recorded. And if that's objectionable to you or uncomfortable, please let me know at that time and we will help accommodate you. The minutes and the agenda can be found out by Googling Humboldt County Behavioral Health, and you will see a part on our minutes and things like that. We start every meeting with a roll call of board members and then an introduction of staff and members of the public. We invite you to share your name, but you're not obligated to do that. We also allow time for those speaking to inform us of their preferred pronouns. So please do that. That's important to many people. So with that, let's get the meeting going. And let's start with the roll call of the board members. Joe?
Alyssa Norman.
Here, she, her.
Laura Montagna.
I'm here.
Steve Madrone. Tim Ash.
Here.
Tim Doty.
Here, he, him.
Madison Flynn. Allison Tans.
I'm here, she, her. Thank you.
Debbie Hartridge.
Here.
Colleen Broderick. Isabella Wotherspoon.
Present.
Danette Kellerman. Vernon Price.
Present, he, him.
Gardner Carlson.
I'm here, he, him. Thank you.
And Oscar McGowan, excused. So we do have a quorum.
Okay, thank you. And staff, would you please introduce yourselves and just give us the title of your job? And this is awkward because we don't have a roll call, but don't be shy of jumping in and introducing yourself.
Hi, good morning, Emmy, or good afternoon. Emmy Botzler Rogers. I'm the Behavioral Health Director. Nice to see everybody today.
Hi, everybody. Paul Bignacki, Deputy Director of Behavioral Health. He, him.
Jack Brazil, Deputy Director, County Behavioral Health.
Hi, I'm Jeremy Nilsson, also Deputy Director over Children's Behavioral Health, he and him.
I'm Oliver Gonzalez, a Program Manager for MHSA and Ethnic Services Manager, he, him.
I'm going to ask just another second for Oliver. Just introduce yourself in terms of your new job. How long have you been on the job, Oliver?
So I've been on the job for about 4 weeks now.
Okay.
Yeah, I've been learning a lot from Kathy. It's been a steep learning curve. But yeah, really happy to be here. I'm hopeful that we can meet in the next November meeting as my first stakeholder meeting with you guys. So,
All right.
yeah.
We'll put that on the agenda. We think we can do that. We're juggling a lot of things. All right, staff, go right ahead.
Hi, I'm Nancy Stark. I'm the Legislative and Policy Manager for DHHS.
Hi, I'm Christine Wolf, the Legislative Analyst under Nancy Stark at DHHS. Happy to be here.
Hey, Sharon. Hey, Christine Messenger, Communications Group, DHHS.
Sonia or Aaron?
Yeah, I'll go. Hi, Sonia Levy-Boyd, you, she, her. I supervise the Humboldt County Transition Age Youth Collaboration and the peer coaches at the Transition Age Youth Division.
I'm Aaron Zell, DHHS Behavioral Health Analyst.
Connie?
I'm Connie Beck, Health and Human Services Director. Good to see you.
Thank
all
you.
of you.
Yeah. And Laura?
She may be transitioning.
Yeah, okay, that's fine. That means different things to different people. But we want to, I see you laughing, Nancy. So let's introduce the public and invite you to say who you are. You don't have to tell us your name if you don't want to. So, and invite members of the public.
Well, I'll jump in there. My name is Megan Harden. I go by she, her, and I'm with Hospital Council of Northern and Central California, working with a number of folks on this call here to advance a pilot project for substance abuse and behavioral health in Humboldt County. So attending today to listen in to what everyone has to say. Thank you for letting us be here.
It's great to have you with us, Megan.
I'm Angela Nielsen. I work with Megan Harden at Hospital Council, and I'm here for the exactly same reasons. Thank you, guys.
Thanks, Angela.
And I'm Becky Messy-Hagler. I'm with an organization called 115 and involved in the project Megan just described. Thank you.
Oh, great. Thought I saw Katie there.
You mean Katie Wilson?
That's what I mean, Katie Wilson.
Oh, thank you, and good afternoon. I'm happy to be here. I'm a local psychiatrist. I just wanted to let you know, Tim, that the Zoom seems to be kind of wonky today, like already 3 or 4 times it stopped and then had to reconnect. So I don't know if that's just on my end, but if you ever don't hear me when you talk to me, that's why.
Thank you. I'm not sure. It could be on your end because most of us seem to be connected. So, but always glad to have you with us.
Thank you.
Hey, Tim.
Yes.
2 things. One, I just wanted to clarify that issue with the recording. What I think Tim was referring to is if there's something that you would like to say that somehow is obviously not confidential, but maybe partially confidential, you don't want it preserved in posterity, then you can let Tim know that you don't want it recorded, and he can ask Joe to turn the recording off for that particular comment, and then it'll go back on record. And the other thing, I wanted to mention was that I didn't quite catch the name of the organization. Several people represented, Megan Harden being the first one, something hospital. And I was wondering if you could explain to us what that is. You mentioned the substance abuse.
Yes, so the Hospital Council of Northern and Central California, they're a member advocacy organization. So we are funded by hospitals. We are a not-for-profit organization, and we were asked by the hospitals in Humboldt County. So previously it was Dr. Luskin Hawk, now Darian Harris at Providence, David Neal at Mad River, and also Matt at Gerald Phelps, to see if we could do anything to help support the challenge that hospitals face of 5150 patients hanging out in the emergency department without, alternatives for their appropriate care. And so the project that we are doing has kind of evolved to work with Dr. Ruby Bayan and Jeremy at Waterfront. They had put forward a proposal for a kind of a triage center, I believe, before COVID happened, that would help to sort of decant some of these patients. And so we're working with them and with the county and the hospitals and law enforcement to kind of revitalize that proposal with local support and see if we can get it moving again.
Thank you. Glad to have you with us. I see your hand up, Emmy.
Thank you.
Yeah, just for context, I wanted to remind you all that this is the group I mentioned a little while back. And I think at the time, Tim, Ash, you were saying, oh, yes, tell us more about that, or what's the work? And at the time I was reporting that they're helping organize us coming together with EDs and other community partners around triage center type facilities. So anyway, they're here today to hear about the work being done here and just make connections in our community.
The other thing that I think we talked about that point, and my memory is failing me right now, but there was a type of facility that happens in hospitals that is not for long-term folks with behavioral health issues or actually 5150 type issues, but actually an acute care part of the ER. And you guys probably remember the name of those types of facilities.
I'm gonna jump in. We're still at the introduction of members of the public, and that can come back with Emily's report or Tim with your communications. Is that all right?
Sure.
All right. Now, the next thing on the agenda is any adjustments to the agenda we need to make that would facilitate the meeting. All right. Hearing no others, I want to invite the public to make their comments at this time. And we ask you to keep those comments to 3 minutes. And I see your hand, Vernon. I want to move on for this, and then we'll get back to your comment, okay? And to talk about the things that we as a board are focused on, behavioral health issues, we ask you to respect everybody while you share. And so we'll give you another opportunity at other agenda items if you want to make a comment at that time. So members of the public, we invite you to come and share your comments with us.
Hi, Tim, it's Katie Wilson here, and I just have 2 questions that, but I'm happy to either ask them now or ask them later.
Why don't you go ahead and ask them now? Maybe we can respond to them later.
Okay.
How does that sound? Okay.
Sounds great. So my first question is regarding the Department of State Hospitals contract with WellPath at the jail to start taking over the psychiatric treatment of the felony and competent to stand trial patients. And I'm just curious for more details, like when does that start? From what I gather, there's going to be an actual inpatient unit at the jail. It's very exciting. And then after people are restored to competence, who will be responsible for their psychiatric treatment? And then my second question is just regarding the DHHS complaint policy and procedure. And I'm thinking that it would be really helpful if maybe the board and anyone in the public like myself that's interested could get an actual written copy of the complaint policy and procedure. So then we could learn like what is the time frame for response, and where do the responses go, and does the BHB get noticed on when there's complaints and the resolution of the complaints.
Okay.
That's all.
I'm sorry, who's jumping in?
No, I just said that's all.
Oh, okay. So we made this available again, but Joe, why don't you send a copy of that as a PDF to everybody that's on the email list? It's probably good for everyone to look at that again. As far as where we are on pathways in the jail, let me see if later on in the reports from the staff, maybe Paul, you can address that as where we are in that process. Are there other comments from the public? Not hearing. I want to make sure. everyone has a chance to speak, but I'm not hearing.
I have a question actually.
Oh, Rosemary, yes.
Hi. If I have a comment about an agenda item, do I wait till after we talk about the agenda item?
No, when it's at the agenda item, that's the appropriate time to make that comment.
Okay, cool. You'll hear from me later.
Great. Thanks for asking that question. All right, so the next item is 2 action items on 5, and one is the approval of the minutes and then the approval of the annual report. So let's go to the minutes. We expect every board member to read them ahead of time. Comments, questions?
I make a motion, we accept the minutes as submitted.
I second that motion.
There's a second. Any other comments about the minutes? Then I can say, hearing no comments about it, I make the authoritative decision that it's passed. And so the next item is the much more significant is the annual report. The members of that ad hoc committee have been working at it. Tim Ash, you want to remind us of who's on the committee? Ad hoc?
Yes, Laura, Allison, Alyssa, and Katie Wilson has participated. Am I forgetting anybody, guys?
All right, great. I'll just say a quick comment, and Tim Ash could add anything else. This is something we do yearly, as comprehensive as we can as a behavioral health board, to report to the Board of Supervisors what we understand, our best understanding of what we are doing in the behavioral health in our community. We're also asked to examine any gaps, shortfalls, things, or challenges, recommendations about that. And so the ad hoc committee spent time working this together. It's great to have it done in a more timely fashion and have a lot of people working on it. So what I want to do is to present it as a whole to the board to approve. If you have some questions or concerns, then about any item, then we'll ask you to go ahead and make them and address them the best we can.
Hey, Tim, can I add a couple things?
Please do.
Yeah, I just want to add, in addition to identifying gaps, we also try to list accomplishments during the time frame of this report, which this report is long overdue and includes several years. But it also is supposed to have accomplishments and our recommendations to both the Board of Supervisors and Department of Health and Human Services. And the other thing is that it also describes those programs fairly concisely. And that was something that staff helped us with quite a bit the first time we did a report of this scale and scope. We wanted to have something that wasn't just really concise. We didn't want something that was just voluminous. Try to get something that could be a resource for the community and the board as far as what DHH is doing, which is considerable, and then take a look at it from the perspective of the community of how it's going.
Thank you. I found it to be an excellent document coming on new, just to really better understand what the department is doing and connections to other programs. It is available online. Is that correct, Joe?
Not yet, not until it gets approved by the Board of Supervisors.
That's right. That's right. So comments, questions, are we ready? Debbie.
Hi, and thank you all for doing this report. Obviously it was a lot of effort that went into it, and it's very useful and interesting. I have a question. Sometimes it can be helpful to, for an overview of what's happening with mental health or anywhere, to have some numerical type of reference, and this may not be it here. In other words, like, okay, here's a program, let's just say it's TAY, or let's say it's Sempervirens. So how many people does it serve annually? That's probably in some other reports, maybe the QI. or something else, but that though I find myself curious about numbers and wonder where I can find those.
Comment, Tim Ash, response to that?
I think that's a fair comment. For a number of reasons, I would recommend that if we were to do that on any particular program, that it be appended to this document when it was available. Obviously, there's a ton of programs,
right?
And it's quite an effort to compile that information. Not that it shouldn't be, because how do we know how we're doing if we don't have, you know, focused information that addresses what we really care about? But if I would suggest, if that's something that you want to advance, that the next go round of the annual report, it be discussed of how and where that might be done. But I would suggest this type of report be a standalone, and then the appendices come later, partly because I don't think you'd ever have a thorough compilation of data like what you're talking about in a given year. And so what do? Just leave some not done. But anyway, we could talk about that at a future date.
Okay. And I do suspect that those numbers exist in some other reports that, or billing or something, that, you know, it would be non-impossible to come up with some list of so
it's a fair comment.
I'm just guessing.
It's a fair comment, and I think Katie Wilson brought that up when we met, and you know, I don't know how, I don't recall talking about it a lot, but I believe that we felt like that was a project in of itself, and probably quite a bit larger in scope than this report was. But it does exist some places, but it's a, you know, a good point too. Is that stuff readily accessible? Could people find it if they were just curious?
Thank you. It might be a thing for a separate report, but I think it's important too. But I see a hand up from Katie.
Trying to unmute here. I want to just echo that. I think that it's extremely important that the BHB and the public have the actual data on outcomes, and because otherwise, basically what we're assessing is the written down programs, but not the actual services being provided. But my main question is just, can we, is there some place where we can have the document? Because I'm looking at the website and I don't see it.
Joe said it's not there until we approve it here at this meeting.
And so did you guys send it out for people for us to review for the meeting?
Send it out to the members.
Maybe I just didn't receive it.
What was that, Joe? What did you say?
We sent it to the members only.
To the board members, BHP.
Okay, so just FYI, the public didn't receive it. I haven't received it, and even though I did help participating, I can't say I've read the entire thing, and I would be happy to do so.
Okay, thank you, Laura. Do you want to make a comment on that? Because I'm wondering why it wasn't sent out to everybody on our email tree.
On the email tree?
Yeah, normally anything that goes to the board becomes a document that everyone can see. Our email tree, everybody wants an email from the board or the department for this board.
Great, take a note of that. And I didn't read that in the manual, or I missed it, but we'll take care of it. I'll send it out.
That's clear. You know, not that you'd see that, but we recently, in our recent bylaws, we tried to make that very clear that anything that goes out to the board for its deliberations should go to everyone who is shown interest and is on the board's mailing list, and everyone who attends a meeting. You know, for example, the Board of Supervisors, if you walk in the door, they have material for you for things that are on the agenda that week. So yeah, we should be doing that.
Can I add that I don't need that to happen this year? I think to get this accomplished, maybe we should just go with what's been done, which I have every faith has been fantastic. But then in the future, perhaps the drafts could be sent to the public.
No, that's true. What we're saying, Katie, is that it is our norm. We just didn't get it done this time. We're making this large adjustment from an in-person, in-room, making anybody who walks in the door available, to doing this online and through Zoom meetings. And that's just one thing that got kind of messed up in the process. So it should be an automatic thing for us to correct, okay?
Thank you, but again, I don't need that to happen for this year.
I heard you.
I appreciate you. Thank you.
You're welcome. I hear that. So do we have a motion? Somebody make a motion to approve this, and then we.
I do. Please, I make a motion. We approve the annual report 2018 to 2021.
Please. Okay.
Oh my, did you want us to approve it?
Is there a second?
I'll second.
Okay,
well, we all second.
Third, fourth, and fifth. Everybody on the ad hoc has seconded it. So this is formally a chance for you to, Katie, I just need to speak to the board at this time. Other comments, because we're at the point of voting right now. So I don't know if you're, okay. So you have your hand up, and I didn't know whether you wanted to make another comment. So
no, I'm so sorry. I'll take that.
No, that's okay, Katie. I'm just trying to communicate with you. So hearing no other comments, questions? Yeah, Debbie.
So is this a time to ask questions, or would we rather vote first, Tim?
No. Formally, we have a motion, and then we have what's called debate. Say yay, nay.
Okay. Well, I do have a question, but just come back to me whenever it's appropriate. No, and it just has to do with the report itself.
Just ask it.
Ask it.
Okay. Yes. All right.
Thank you, Mr. Ash.
So I'm curious about many things, and that's a testament to all your hard work. Thank you. So what does it mean adding private pay clients to the TAE first episode psychosis program? Just briefly, I understand right now people apparently, in order to be in that program, they have to be qualified for Medi-Cal. Is that correct?
They have to be what?
They have to, if private pay patients are not currently allowed in or accepted in the TAE program, and I think there was some other program too, that means then that those patients who are accepted or participants are people who have Medi-Cal, Medicaid. Is that how it works? What's the difference?
Well, let me say one thing, and then I would say for, let Jeremy or Sonia answer the specifics. But as I recall the language, what we were saying there was that we wanted to ensure that private pay insurance people that are in the transition age group there would have access to that specialty mental health program, because it doesn't otherwise exist in the community. Some communities it does, but this one it doesn't.
Okay, so I think I understand that currently private pay patients are not accepted, right?
I don't know, Jeremy?
Yeah, that's correct. Generally, for TAE and for most of our county behavioral health services, we do focus on the specialty mental health population that do have Medi-Cal. If someone has private insurance, generally we work with them to find a provider in their insurance network to get services that they need, but that's generally not through county services.
Right.
So.
And that works for typical clinical work. It doesn't work for specialty programs that are actual programs, a certain type of wraparound programs, at least like the Navigate, which is the first episode psychosis programs. In such a small county as this, they don't exist. So there's nobody in network that these kids can go to. And working out a way for reimbursement to happen through the companies or just picking them up and helping them out is something that our recommendation is that we
Okay.
figure out a way to do that.
Thank
Yeah,
you. That's what I wanted to know.
That's what this is, the level of recommendation. We have a lot of recommendations that need to maybe be dealt with more specifically, but that's where the annual report is making. I think that dealing with the whole medical and insurance-based nature of our work is worth taking a look at, perhaps in a little more length, that we all get a little bit better educated. So we have a motion on the floor, and we have a first and we have a second. Are you ready to vote? All right, everybody say aye or raise your hand.
Aye.
Are there any objections? Abstentions? All right, it's so ordered. Moved, seconded, and carried. Thank you for everyone on the ad hoc committee and got it done. And so we then move on to our presentation, and that I kind of pushed this to happen. It's very, very early. It's the Care Court. I hope you've all had a chance to get some basic information on it. It's a big program. So I don't want to say any more, but just a kind of preliminary introduction to what it's about. And so, Sharon, are you the one that's going to make this presentation?
I'm not. Nancy's going to make the presentation, but I'll be in control of the slides behind the scenes. So I'm here to support.
It's good to know who's in control. So.
Yes.
Go ahead.
Sharon, go ahead and share your screen. Okay. Thank you very much, Tim. Hi, everybody. For those of you who may not know me, I'm Nancy Stark. I'm the Legislative and Policy Manager for DHHS. And I've been asked to talk a little bit about Care Court. And Sharon, if you could put it in presentation mode, please. So Care Court, I bet most of you have been hearing about this in the media. Care Court stands for Community Assistance, Recovery, and Empowerment Court Program. And it was certainly a priority of the governor in this year's legislative session. Next slide. Give Sharon a minute to start the slideshow.
Is this showing on my screen? It's showing up. I can't see what you're seeing.
It is showing up, but if you could put it into presentation mode, so it's just the one slide, that's great. Okay. Hopefully we'll see it show up here in a second.
Yeah, but I can't do it.
Right. It's turned to black.
I can stop sharing the reshare.
Give us one moment for technical difficulties.
Of course.
Patience.
Is that?
No, I'm still seeing a black screen.
Oh my gosh, it's my screen. Okay.
Try it one more time. It's okay if it's not in presentation mode. I just need to be on slide 2, please. There we go. Perfect. That looks great.
Oh, thank goodness. All right. Bye-bye.
Okay. All right. So what is Care Court? It is basically a court-ordered treatment plan for people with schizophrenia or psychosis disorder who lack medical decision-making capacity. This does rest in the civil courts. This is a civil court process, not a criminal court process. It is a statewide mandate. So this is one of the things that makes it different from assisted outpatient treatment or Laura's Law. It is a statewide mandate, and there is no option for counties to opt out. It's going to move forward in 2 cohorts. The first cohort of counties is going to implement no later than October 1st of next year. The second cohort, in which Humboldt is included, we must implement it no later than December 1st, 2024. The state has launched a website around Care Court, and I've included the link here. I'm going to send this out to Joe after the meeting to make sure that you all have a copy.
Great.
Next slide, please. Next slide, Sharon. Okay. So Because this has gotten a lot of media attention and Care Court was a priority for the governor, they have a statement. I thought I'd talk a little bit about what the intention was here. So the intention, this is the statement on the state's Care Court website, really that Care Court is intended to be a new pathway to accessing services, to avoid hospitalizations and incarcerations, to prioritize these individuals for services and supports, to honor self-determination to the greatest extent possible, and to hold counties accountable. Next slide, please. So here's what's known as the legislative intent language, and you can read this later when Joe sends it out. I included it because sometimes when the legislature passes a significant or perhaps controversial new law, they sometimes include what's known as legislative intent language right directly in the statute. So the legislative intent language for Care Court, somewhat similar to the state's website, talks about people suffering with untreated schizophrenia spectrum and psychotic disorders, leading to homelessness, incarceration, hospitalization, conservatorship, premature death. This desire to move upstream, to act earlier. Next slide. Again, this notion of accountability for counties, self-determination, and ensuring access to services and support. So those are kind of the themes in the legislature and the governor's intentions in passing Care Court. Let's get to how it actually works. Sharon, next slide. So who qualifies for Care Court? In order to qualify for Care Court, the person must be at least 18 years of age, currently experiencing a severe mental illness, and has a diagnosis identified in the disorder class schizophrenia spectrum and other psychotic disorders. Must be not currently clinically stabilized in ongoing voluntary treatment. Next slide. And at least one of the following must be true. They must be unlikely to survive safely in the community, or Care Court is needed to prevent a relapse or a deterioration that is likely to result in great disability or 5150s, danger to self or others. Participation in Care Court must be the least restrictive alternative, and it must be likely that the person is going to benefit from this intervention. Next slide. I want to point out that this is also not limited to Medi-Cal beneficiaries. It can be people with private insurance or no insurance at all. It's also not limited to those experiencing homelessness. I realize that the press is really focusing, right, on this highly visible population in terms of homelessness. You don't need to be homeless to qualify for Care Court. The governor's office is estimating 7,000 to 12,000 people statewide would ultimately qualify for Care Court. Counties, as well as other stakeholders, think that that's likely an undercount. And it's certainly an undercount of the number of people who will be referred or assessed for Care Court. Next slide. So who can petition the court to start this Care Court process? This is one of the main differences between Care Court and Laura's Law, or assisted outpatient treatment. With Laura's Law, or assisted outpatient treatment, it's really county behavioral health that begins that process. With Care Court, any number of people listed in the statute can start this process. So that can be someone that the person lives with, it can be a family, a hospital, a behavioral health provider who has a relationship or has seen the person within the last 30 days. First responders, so this is law enforcement, firefighters, paramedics, EMTs. Of course, the public guardian, adult protective services, or county behavioral health could all start this process, as well as tribes and tribal court, or even the person themselves could start this process with a petition to the court. Next slide. So what's in that petition to the court? What information would need to be provided to get this process started? Well, the name of the respondent and an address, if that's known, the petitioner's relationship to the respondent, any facts that that petitioner knows about the respondent. Respondent means the person who's being referred to care court. And either of the following, either an affidavit from a licensed behavioral health professional that the respondent meets the diagnostic criteria, meaning schizophrenia spectrum or psychotic disorder, or evidence that the respondent was detained essentially on a 5150 hold twice, with the last one being within the last 60 days. So that's what's in the petition to the court to start the process. Next slide. So what does that process look like? Once the petition has been submitted to the civil court, again, we're talking about civil court, not criminal court, the court would review that and just kind of check the boxes and see if on its face, the person might qualify. Then within 14 days, the person would be notified, appoint legal counsel. So if the person does not have their own attorney, it's going to be probably most of the cases. This really rests on legal services, like Legal Services of Northern California, self-help centers, or as a last case, public defender. I suspect in Humboldt County, much of this will rest on the public defender's office. Also within that 14 days, county behavioral health must submit a report to the court just describing what our previous relationship with the respondent might have been. So if we've had previous contact. From there would be a court hearing on the merits of the petition. From there, from within 5 days, the judge would make a decision whether to proceed with this care court process or dismiss.
I want to just jump in here real quickly.
Yeah, please.
I want to save questions later, Alyssa, but if it's really pertinent now, go right ahead and make it.
Thank you. Why would an individual need a public defender with care court?
Thank you.
Sure. Well, it is a court process. It is a civil court process, but it is a court process. And anytime that's part of the legislation that the respondent would have the right to representation in court. So they'll be appointed legal counsel to help guide them through this court process. And I'll talk a little bit more about the respondent's rights in just a few slides. So then from there, let's say that the judge decides to proceed with the care court process. There would be a case management hearing. Next slide. That would be followed by a clinical evaluation hearing. From there, within 14 days of the clinical evaluation hearing, the county would work with the respondent to develop a care plan. And I'll talk a little bit about what's in that care plan. Then there would be a care plan hearing in the court. Once the care plan is court approved, meaning the judge has to look at the care plan that we've come up with the person and approve it. If that care plan is approved by the judge, it starts a 1-year clock. Following that care court plan approval, there would be a 60-day status hearing, check-in hearing. And there could be other check-in hearings depending on what the judge would like. Then there would be a 1-year status hearing.
I just wanted to jump in again. Please mute yourself if you can. Otherwise, we might get background noise.
Cool, thanks. At the 1-year status hearing, any party involved can request up to an additional year of care court services. After that 1 year is up, the person may graduate from the care court process. There could be up to a one-year extension. So the maximum time here is 2 years. The care court process could be terminated. And that could, if the things hadn't worked out, it could be referred to conservatorship, to the conservatorship process. Next slide. So what's in that care plan that the county behavioral health and the respondent would be developing together? CLARE plan means an individualized, appropriate range of community-based services and supports, which include clinically appropriate behavioral health care and stabilization medications, housing, and/or other supports and services as appropriate. So this sounds a lot like full service partnership, right? This says whatever it takes, whatever the person needs to remain stable. Throughout the legislation, psychiatric advance directives are encouraged. I want to note here, because of the media that's been involved here, that housing is not guaranteed just because you're a care court participant, right? This is not just for people experiencing homelessness. The person might already be housed, but for people experiencing homelessness, counties may prioritize care court recipients for available housing, such as No Place Like Home, right? The county of Humboldt, we have a number of permanent supportive housing units. We could choose to prioritize care court participants for those particular units. But housing, is not a guaranteed just because you've been referred to care court. There was funding included for what's called the Behavioral Health Bridge Housing Program in this year's past budget. We don't have a lot of detail yet, but the governor's intention with that pot of funding was to create new transitional housing units in which care court participants would be prioritized. Next slide. So I talked a little bit about respondents' rights. So this is what I wanted to touch on. These are the respondents' rights in a care court proceeding. So these are things you've probably seen before, right? Receiving a notice of the hearing, copies of the evaluation, be entitled to be represented by counsel at all stages of the proceedings, regardless of the ability to pay. Be allowed to have a supporter with them, be present at the hearings or to not be present, to have the right to present evidence, call witnesses, cross-examine witnesses, and to appeal. Next slide. I get questions about medication. So I really wanted to put exactly the language that is in the statute. A court may order medication if it finds that the respondent lacks the capacity to give informed consent. The medication shall not be forcibly administered, and the respondent's failure to comply with a medication order shall not result in a penalty. So I wanted to make sure that you have this language. This is the exact language that's in the legislation. Next slide. So let's just want to talk a little bit about funding. This is really an unfunded mandate currently for counties. So far, the only funding that's been allocated is for the courts. The courts have annual ongoing funding to implement that. That's that $37 million annually for courts. This doesn't cover the public defender. And there was $31 million set aside for training, technical assistance, IT upgrades to do all of the data reporting the counties will need to do for this. And that first cohort of counties got a pot of funding of $26 million for startup. There's that $1.5 billion for the behavioral health bridge housing. That's intended to provide transitional units where care court participants would be prioritized. We think this is going to be competitive grants, and you would be more competitive, and counties would be more competitive in their applications if they do explicitly prioritize care court participants for these transitional units. I guess what I want to point out is that the California State Association of Counties estimated that the actual cost to counties is about $780 million to $1.3 billion annually. The Assembly analysis, which is kind of that nonpartisan analysis, said it more broadly. They just said hundreds of millions of dollars. They didn't nail it down to $780 million. They just said hundreds of millions of dollars. So as of right now, we have no indication if there will be any additional funding to implement this. What we're being told is kind of use your MHSA in realignment and just reprioritize. So certainly in the year ahead, we will be advocating to our legislative delegates that that we would like additional funding to implement this new program. Next slide. Yeah, so Tim, happy to answer any questions. I hope that provided a decent overview. And I'm happy to take any questions that you might have. Alyssa?
MHSA, just so cancel everything that's being done with MHSA to implement care court. That's what they're saying so far?
We're being told to expand our full service partnerships. Some of this I'm going to kind of leave Emmy a little bit.
Okay.
If Emmy has anything to offer, she's welcome to chime in. But
yeah, I would just say, Alyssa, in response to that, you're right on point that the issue is there's not funding that's coming with this. And so they're recommending, oh, we'll use the funding you already have, either MHSA or realignment or other funding. And so it will be a challenge for us to figure out where that funding will come from. And if any of it comes from MHSA, how we move things around to not lose programs that we're already doing that are valuable. But that is the puzzle that we're being asked to put together right now.
That's enough to make a person cry. It's like, but the population that's going to be helped are they trying to jump in and help people who are the most vulnerable and experiencing the most psychosis before they end up in criminal court as a byproduct of their symptoms? Is that what we're doing?
That's much of what's included in the legislative intent language and on the language on the state's website.
Okay, so it's good, but there's no funding. Okay, thank you.
So I want to let everybody know we have more hands going up. I want to give everybody a chance to respond, but I'm going to use my little smartphone timer, okay, and ask for 3 minutes. And if we need to come back, you can come back. All right. I see the next hand up as Katie.
Hi, thank you so much. I actually advocated at the state level against care court unless they were going to add funding, and also that they were going to share the care across the counties, so that, say, if one county has more board and care beds and a different county has more IMD beds, that those resources could be shared across the state. And unfortunately, we can all see that I wasn't successful. In other words, a state didn't, seem to take that input. But I'm wondering exactly who at DHHS is involved with advocating at the state level.
So advocacy work is done through our Board of Supervisors and our county administrative office. We do have state lobbyists who the county contracts with. We also have our state associations. So that's CSAC, the California State Association of Counties, and CBHDA, the County Behavioral Health Directors Association.
Okay, so I was participating in some of those hearings at the state level. I actually participated telephonically, and there were people there from the state organizations, including the county directors, and they opposed it, rightly so, because it doesn't come with any additional funding. Is our Board of Supervisors aware of this? I certainly didn't hear that anybody besides me was advocating about this in the whole county.
Yes, our County Board of Supervisors wrote several letters of concern, largely around the funding concerns.
What about the idea of sharing the care across counties and having the state allow people to have flexibility so that everyone across the state would have the same access to treatment.
I'm going to pass that to Emmy. I know that we do placements in other counties.
I'm not exactly sure of the question, Dr. Wilson.
Did someone advocate specifically for that? In other words, did someone from DHHS specifically advocate that the care court proposal only be implemented if the counties that didn't have the resources available would be able to have their patients go to other counties that had those resources, like board and cares and IMDs?
The advocacy that I do, or that other behavioral health admin contact and communication with them about the issues that are of concern, and then they take them forward.
Okay, and the reason I asked that, Emmy and Connie, is that you both have at other meetings said that we really need to advocate at the state level. We need to, and I've taken that upon myself because, as you know, I'm really a fan of having equal access to treatment. But I felt like I was kind of all alone in that. Like, it didn't seem like, anyway, I'll look forward to having people be very active specifically about the sharing the care, because to me, it's ridiculous that people who live in Sacramento or LA have access to more treatment than people who live in Humboldt County.
Okay, thank you. Dr. Wilson, I see another hand up, Laura Montagna.
So the 26 million for the first cohort, that's startup funds, right? So that is some money. Just pointing that out or clarifying, is that correct?
Yes, they did include $26 million just for that first cohort of counties. And that was intended to get counties to volunteer to go first. There's no guarantee that the second cohort of counties will have access to startup funding. That's what we'll be advocating for.
Got it. Thank you.
Thank you. I just want to note, Joe, that Danette is with us, and so please count her in as a board member who is present. So the next hand I see is Danny. You want to just introduce yourself quickly to us, Danny?
Sure. My name is Danny Medina. I work for an organization called CAMPRO, the California Association for Mental Health Peer-run Organizations. And I have a question about what qualifies a public defender to represent a person with one of these mental health challenges. Are they going to get some type of special training, or, I mean, do they even know the verbiage? Are they versed in mental health, these public defenders?
There was some funding set aside in the judicial, the pot of money for judicial for training. Whether that's just for the judges or the public defender, I'd have to really dig into the language and see if I could figure that out. But really, I don't know the answer to your question.
Yeah, because representation is going to be huge. And as you know, as I know, that it takes a lot of patience to deal with somebody who is probably not always going to be cooperative. And so that's a concern of mine in my county as well. I also was wondering, will the individual going through the early periods of the process, if they're homeless, how are we going to keep the individuals on track through the 14-day and then the 60-day? And are they going to get a bed somewhere, some type of housing while the early part of the process is going on? Or are they going to be forced into hospitalization? Any of those?
Good questions. Nancy?
But I almost kind of want to turn this over to Paul or Jack for what is current practice. But certainly that seems to be the intent from the legislative intent language, and the governor is to avoid, is to move upstream, right? To avoid the hospitalization and incarceration. But I do know that we have our housing outreach and mobile engagement unit that does street outreach. And Jack or Paul, if there's anything you'd like to add to Danny's question.
I could just say really quickly, and Jack and Paul can chime in too. I think to your point, Danny, that having a stable place to live, to utilize, maximize this process is really important. And so that's part of what the governor is saying he wants to do is support housing or transitional housing during that time. We also, just unrelated to Care Court, do have our local resources, the resources that we do have that.
No, let's go on with a couple more minutes. This is important.
We try to connect individuals. Me? Oh, okay. Sorry. You confused me. So we also have our local, system of care that we have staff linking patients to, no matter what services they're in. And so hoping to get them stabilized with housing in addition or simultaneously to getting the treatment that they need. I don't know, Jack or Paul, if you have anything to add.
So that's got to be a huge concern for an underfunded county such as yourself, that you have to share funding from some other source in order to make sure that this goes through seamlessly, I guess I would say. Thank you for your time.
Thank you, Danny. Thank you very much for participating. I see a couple more hands up. I see Tim Hatch.
Yeah, just real quickly, presumably some of the people that will go in the Care Court are already like in CCT and some other programs, so that might be a little helpful. And I just want to really quickly address, Danny, your question as far as training. I think that's a good point. The one thing I would say is that those folks have a lot of experience dealing with this population, doing their jobs normally, defending them from criminal charges. So they probably will welcome the opportunity to help upstream. And I think we've got a couple, Isabella Danette here might speak to that. But anyway, but my questions were though, well, comment that the IMD exclusion is key here. We need to advocate that the state do everything they can do to get us so that we can get reimbursement for folks that are in facilities or any kind of a facility that we can get federal reimbursement. This whole idea of having the MHSA be the kind of default, I find, I don't know what you would say, insulting. We were, that bill was passed with the thought that individual communities would be able to self-determine how that money was spent, how to best spend it in the community. And it wouldn't be the first time that it's been used as a kind of a slush fund for unfunded mandates. I just think we need to push back on that a little bit. And even though it's the population needs the help, the legislature should be looking at other providing funds. And I will say that one thing, that the state has a long habit of throwing stuff against the wall to see what sticks. So I wouldn't be surprised if that's what they're doing right now, is throwing it out, making a scramble, and then using that as a way of determining how to provide funding at a future point if we're not in a recession, So anyway, that may be what's going on, but I think it's a lousy way to do business. That's what they do sometimes.
All right, thank you. I see another hand up. Tim, did I cut you off?
Nope.
Okay.
Thanks.
Rosemary.
Hello. So I help facilitate the Youth Advocacy Board at the TACE Center through HCTC, the program that I work for. Transition age youth are 16 to 26 for those that needed a refresher. These are also the times, I know that this program is 18 and up, but those are the times that most youth will have their first psychotic break or schizophrenic break. And I just don't believe that this program is going to be beneficial to youth, not let alone, you know, adults older than that. Our Youth Advocacy Board actually wrote a letter in opposition to this back in May that we sent to our different California senators. They can speak much more eloquently about this than I can. If you want to read that letter, I can send it out for public comment minutes. But essentially, the youth sent me here today to say that we should not have care court in Humboldt County. If you look on the website, Governor Newsom met with some larger cities and had meetings with them, but did not represent, you know, our rural counties that are similar in size to Humboldt County. Mental health, MHSA funding helps fund our program, and our youth definitely don't want that to be taken away to benefit this. And even though it is civil court, it is seen as very punitive if you can't complete it. Yeah, and that just like leads to more systemization. That's what our youth are not down for. So one thing that we can do is I can urge, you know, the Behavioral Health Board, tell the Board of Supervisors to sue to stop this from happening. Seems like a lot of people that have commented so far aren't cool with it. So that's my public comment. Thank you.
Thank you, Rosemary. Tim, oh, you did put your hand down. And so, Isabella.
Hello, good afternoon. My name is Isabella, obviously, sorry. I'm a Behavioral Health Advisory Board member, but also in my professional capacity, I am actually the in-house social worker at the Office of the Public Defender, and we're joined here by another board member, Ms. Kellerman, who is also an in-house social worker at our sister office, Conflict Counsel. So something that's very unique about our public defender office up here locally, at least, is that we do have in-house social workers through grant funding. And though I'm not really going to express, I don't think it's like appropriate for me to express an opinion one way or the other about this, though, like I concur with the majority that this seems to be quite an undertaking. I foresee that having in-house social workers, a vast majority of the client population we serve, both the attorneys in our office as well as us. The reason why we even got this grant funding is because many of our clients are actively houseless. Many of them are struggling with dual diagnosis, whether that be substance abuse or severe mental illness. So we as social workers here at our office are very accommodating when it comes to that client population, and that is what we usually work with, and that's usually who we serve. And so we on our own actively house individuals, partner with local agencies, move people in, physically on ourselves, whether you're talking about getting them into shelters, getting them into transitional living environments, and getting them with the aspiration to get them into safe and stable permanent housing. So I just want to address that because Mr. Medina specifically raised a lot of really important questions, and I wanted to answer those for you. We are in a unique situation in that, we have in-house social workers here at our offices, but that's basically my stint on that. So I hope I answered some of that.
Thank you very much. Alyssa, you're back on, but I wanted to see if anyone else had questions or comments. I'm mindful of our time. This is an incredibly important topic. So I just wanted to say that, and Alyssa, you're back on.
I think that there's some important background. I think There's this documentary I saw recently. It was put out a couple of years ago. It's called Bedlam. Maybe some of you have heard of it, maybe you haven't. Governor Newsom was in it, and he was learning that California state prisons house mostly individuals experiencing mental illness as a form of treatment for mental illness. That since the institutionalization in the early 1980s, that has been the way that medical services have been provided for most of the nation. And when he learned that, it looked like it was quite profound. And then a couple of years later, we hear about Care Court, which is something he's pushing through, which is supposedly to address that a lot of those concerns. So if you haven't seen it yet, it's the first part of the story, or, you know, part of the story. And again, it's called Bedlam.
All right. Thank you, Alyssa. I see two more hands up. Mr. Ash.
Yeah, I just remembered one thing that I meant to say earlier, and that was just to ask, is DHHS, have they tried to estimate what care costs would cost in this county, Care Court would cost in this county, and also which would be related, what kind of caseload numbers they think that we might have? First question. And the second thing is kind of to respond to Rosemary's comments. I mean, it's a bill, it's passed, it's a reality. The one thing where I think she makes a good point is we need to stop and think, are there some advantages to looking at the TAPE population as unique? And there's clearly this whole thing, there's an intent to be upstream with our intervention with folks before they're 5150. I think that would be a goal of the TAPE program as well. And Care Court is one way of accomplishing it, but as we talked about with AOT, outreach and, you know, honestly, coercion, if you look at the Care Court, be an option, but possibly the TAPE program could, you know, work, or DHHS as a whole could work with TAE with the idea that this is out there. What could we do to avoid going that route? Because nobody likes to go through the court system. If we can figure out a way to identify the folks, outreach them, and provide them with services that keep them from getting into a Care Court, a formal court process, I think everybody would be ahead, both in terms of cost and effectiveness.
Thank you, Tim.
Thanks, Tim. Paul and I are actively working to nail down estimates for how many people might qualify specifically in Humboldt County and what our specific Humboldt County costs might be to implement this. And I would also just note that the advantage to being in the second cohort is that we have a whole year to learn from the first cohort. So at least I am hoping that we have at least get some of the bumps out. If not, kind of get an indication of best practice of what's working and what's not working, and bring the best of that here. Because this is a statewide mandate, we do have to implement it. So we'd like to implement it in a way that takes advantage of the lessons learned from the first cohort. And that also gives us time to get back to you and let you know what information we find out.
Thank you.
Thanks.
Katie, back to you. I'm only going to give you 2 minutes, but because we need to move on, all right? Katie? Oh. You said
Katie,
you might
put her
have...
hand down. I just
Hi there,
wanted
can you hear me?
Yes.
So just two things. One is a big shout out to both Danette and Bella, and to assure Mr. Medina that we have one of the most psychologically sensitive defenders, public defenders, and conflict counsel attorneys. And I work closely with all of them. And I've just been constantly impressed with how caring they are. So I really appreciate your concern, because obviously we want everyone to be treated kindly. And I think that that does happen up here. We are lucky in that regard. And then just a general thing about the AOT and the care court and mental health diversion. I think one of the bottom line services that we absolutely need more of in Humboldt County is staffed supportive board and care beds. And until we get that, I mean, a lot of these folks with anosognosia, they're never going to recognize they're ill, and they're never going to recognize or agree that they need medications. And those folks may comprise 50% of all patients with psychotic disorders, schizophrenia related disorders. So that means that there's like 50% of people with severe mental illness that are not even receiving treatment because they don't know they need it and they don't seek it out. And so it is quite true that the penal system, the CDC and county jails are still the largest treaters of severe psychiatric mental illness. And I think a big part of that is that we don't have enough staffed supervised board and care beds in communities to help people stay on their meds and stay clean and sober in the community, even though they don't realize that they're ill. Okay, thanks very much.
Okay, thank you. I want to move on. I have a couple of things to say. We have 45 minutes to cover a lot of other things on our agenda. One, it is my intent to have the care court as a regular agenda item. We can keep informing ourselves and updates. Our implementation is a year away. And so we have time to keep bringing these things up and maybe on more specific issues. The second thing is that the California NAMI conference, there were 2 people from the state offices responding and talking about this. And the comment that I remember most is care court is a doorway. On the other side is a mess. And basically saying we have a lot of work to do, and there are people looking at funding and looking at other models. So that will be an ongoing process along with the prototype. So we have a lot to learn about this, and we can keep addressing it as we go on. So those are the comments that I wanted to make. I am going to move us on then to the next. And Nancy, thank you. Thank you very much. And I appreciate you being able to send it to Joe and send it out to the rest of us. There's just a lot of important things to keep thinking about. So thank you again. Nancy, we'll move on. This is a time for the board members, we call it communications, to bring things up you'd like to share with the Behavioral Health Board. And so I'll make that time available to board members. I see your hand, Debbie. Can't hear you, Debbie.
Oh, it was more than just seeing my hand. Yes, Tim. Yeah, I just wanted to mention that NAMI Humboldt, of which some of us are members, will be tabling at the Mad River Hospital Health Fair this Saturday. And I thank the health department education staff for giving us some of their goodies so we could have some fun things to have at our table besides just information. Also, we'll be tabling at the Eureka Fair tabling event Wednesday. That's going to be, that's sponsored by the CSET team, or organized by the CSET team, I believe, St. Vincent de Paul, etc. So we're happy to have these opportunities with COVID sort of a little bit in the background these days. We haven't been able to do anything like that in a few years, i.e. getting out in the public and talking about mental health and mental illness with people.
Thank you, Debbie. I see 2 more hands up. Tim Ash.
Oh, I'm drawing a blank, and if Kate is on the line, she could help out. But I just wanted to say, when she was talking about it, anosognosia, it reminded me of a book that I can't remember the author's name, but it's something like I'm not sick and I don't need help, something like that.
That's it. Yeah, that's the name.
Yeah.
I can certainly tell you that. But I think NAMI Humboldt actually has some copies available for borrowing. Is that right, Judy?
Yes, we do.
Yeah, it could be also in the county library. I believe we've donated copies to the library.
Awesome. Yeah. It's I'm Not Sick, I Don't Need Help by Javier Amador.
Yeah.
I think anyone who treats patients with severe mental illness should read that book.
What I was going to say is that that I've read the book, and I actually find it the most useful book I have ever read on the issue of psychosis and folks with serious mental illness. And when you mentioned that, it just occurred to me that as a group, as a community, I think there's a huge lack of understanding of the lack of insight and anosognosia. And it occurred to me, Katie, that since you've got some training in it, it might be a really helpful presentation. I know you're looking at other presentations in the community, but to talk to this group at some point in the future. And
yeah, I'd be very happy to do that.
Great.
I would be excited to do that. I agree, because I did attend some training directly with Dr. Amador. So, and I agree with you, Tim. For me, I read that book 20 years ago, and it has had a profound effect on my clinical work with folks with anosognosia. So I don't think I would be the kind, compassionate psychiatrist, hopefully, that I am if I hadn't read that book. So, yeah.
Thank you. We can take that to the executive board because we plan those kind of presentations, and it sounds like a good thing. Thank you. Alyssa, we're on communications.
So next week is the North Coast Stand Down. It's happening Thursday, Friday, Saturday in Fortuna. It's huge. They provide tons of services. My organization that I work with, we're going to be there all 3 days. If you're interested in getting the information out to your clients, or, you know, just for yourselves to go have a look it up. North Coast Stand Down, 3 days. It's a beautiful, beautiful thing.
Alyssa, what is Stand Down?
Stand down is when you're in the Army and you go out, you're doing training, you're and then there comes a point where you get to stand down, which is you get to leave base, go get services, and make sure to get caught up on everything you need. So now this is for veterans who get to continue, you know, that they get a stand down every year where they can get new boots, new services, veterinary services, doctor services, social support services, just all sorts of wonderful things. And and we also provide or they also provide lunches and everything. So it's really great.
And haircuts.
Oh, and haircuts. There you go.
And haircuts. Thank you. Danny, this is a time for the board to make their reports. So I'm going to ask the board to continue to that. Hopefully we give you another time. Your comments have been very, very helpful. Anyone else from the board has some communications? Okay, then we'll move on to Connie said she had to go to another meeting. So we'll go to Emmy, the Behavioral Health Department Director.
Yeah, hi. Thanks. I'll just, much of what we've already talked about are kind of the current issues that I would share. I'll mention a few other items, and if you guys have questions, we can talk more about them. One is just kind of an announcement. The CIT training is next month, which we're a partner in, and NAMI is as well, I believe, in law enforcement. So anyway, I'm always excited when that comes around. We did secure a location for the crisis residential treatment facility. That's really great news. We're in the you know, longer term negotiation process, and it looks like it's all going to fall in place. And I just say that with crossed fingers because I don't want to jinx it, but it looks like we've got this location on N Street. We are doing some really good work with our education partners and others around the school-based the school behavioral health incentive program, which is funding that's coming.
You're frozen.
From DHCS through partnership. Still?
No, I can hear you.
I'm back. Sorry,
Yeah,
I'm having awful internet issues. So that's we're partnering around doing a gap analysis right now to really understand in Humboldt County what the needs are for on-school campus services for students. And the last thing I wanted to let.
You're frozen again.
This group know, which is not great news, is Raina. Am I back?
Yeah, but I didn't hear the last thing you said.
I'm going to say it again. So Raina West, our SUD administrator, is leaving. So that's a real loss for us. It's good for her. She's doing it for good reasons, but I just wanted this group to know because we'll be recruiting to fill her position.
Thank you, Emmy. Any questions or comments for Emmy? Are there any other deputy directors who have some updates to share?
I don't have anything to report. Thank you.
Yeah, nothing specific from the children's world.
Tim, I have a question for Emmy.
I see it, Tim. Go ahead.
Yeah, Emmy, I was just wondering if you have any updates. I thought I heard somebody say something about Roberta Hawk leaving, which reminded me of what I brought up earlier about the in-house specialty psychiatric ERs and all your communications with St. Joe's and Mad River as far as boarding, and if you could tell us where you're at with that right now.
Yeah, thanks for asking, Tim. Sorry I didn't mention that. So this group already knows that Dr. Luskenhawk left a little while ago now, and she's been replaced by Darian Harris. He's the new CEO for Providence. I've had the opportunity to meet with him a couple times. He came and toured SV, which was really great. And we had another meeting over at Providence with him and some of the other individuals on this call who already named themselves as kind of supporting local hospitals and partnership with behavioral health. So I feel really hopeful about the relationship with Darian and Providence going.
Okay, you're frozen again.
Forward. I think he's very engaged, sorry. I'm going to turn off my camera in case that helps. He's very engaged, very responsive, very kind of open to how we can partner and work together. And as mentioned at the beginning, really what we're doing right now is trying to bring together community partners, including the EDs and others, around looking at what kind of local facility that could help ease the impact of people on 5150s in the EDs and at SV, frankly, is possible. We're looking at a proposal from Waterfront Recovery Services that Dr. Bayan has lifted up in the past. I think we've talked about that. And also maybe how to kind of create something from that proposal that would be inclusive of a triage center or other opportunity to kind of receive, evaluate, support individuals in crisis, as opposed to just having them go to the EDs. So I think there's lots of really good positive work that's happening and that will continue to happen over the next weeks, months, and years. And I'll try to do a better job reporting out each time we're here together. So sorry for that.
No, thank you, Emmy. I heard a report from Ruby, who I've known for quite a while, about Waterfront, and it was a great report, very thorough, and lots of things that, and maybe sometimes you can give us a presentation on that as well. So we're moving on then to the AOT update. This is your time to shine, Jack.
Very good. So
I don't mean the top of your head either.
Right. I was actually just thinking that. I'm hopeful not blinding anybody. So AOT, yes. So we've been up and running now since July 1st, though our referrals really started about mid-July to EA Family Services. We are up to 7 participants. We have not, we're still with those folks in like the outreach and engagement phase of AOT, so we haven't petitioned the court yet for any involuntary services, though some of that is a little bit imminent. We haven't crossed that threshold just yet. So we've got seven participants. There's been, I think, of those 7, 2 that have agreed to voluntarily get services, meaning that they're willing to meet with EA and do treatment with them. And then the other 5 are still, as I mentioned, in that kind of the outreach phase. We're just trying to work with them and help them voluntarily agree to get services, you know, in the long term. So that's kind of where we're at with that. It seems like, you know, from the reports I've gotten from EA that it's happening and it's working, and that you know, their experience has been that you know, they're able to work with community providers or agencies to kind of help get in contact with folks, and that's been going really well. So,
Jack, I'm going to jump in again.
Yeah.
What is EA?
EA is the community-based organization that we contracted with to provide assisted outpatient treatment. I believe it's Environmental Alternatives is the name of their organization.
Thank you. We just want to keep.
Yeah, you bet.
Language everybody can understand. Any comments or questions for Jack about AOT? All right, thank you very much.
Tim, I do have a question. I am slow to get the mute off. I was just wondering, Jack, I was a little surprised that that you're using EA to do the voluntary folks.
Well, you know, that's a good question. So there is the way that it works, right, is that these are folks that we know have historically not agreed to voluntary outpatient services, right? So those are the kind of referrals that go to EA. EA meets with them, does some outreach, and if those individuals are like, yes, I would like to get more services, you know, therapy, psychiatry with you, then we would probably let that happen for a little while, right? Meaning like things are going well and this person is not ending up back in the jail or the psych hospital. And so we'll let that kind of go. And then EA and County Behavioral Health will kind of evaluate those clients moving forward. You know, are they a good candidate to move to traditional county behavioral health treatment, or what, you know, what other kind of treatment might they benefit as opposed to keeping them on with EA. But I think, you know, those 2 that I mentioned, right, they've agreed, and I think they've agreed because they like the folks at EA, and so that's working for them. So that's kind of that. But we would evaluate that though, Tim, for sure, because we don't want to clog up EA slots with folks that otherwise are pretty agreeable.
Thanks.
Thank you. I wanted to go to Paul, but thank you, Jack. Just a quick update on the 988. It just got launched about, what, a month ago or so? How's that working here in town?
You just want a quick update about 988?
Yeah.
We really still haven't felt any impact from any call transfers from the regional call center. So our call volume is the same, no uptick still. You know, I'm sure they're still, you know, ramping up, and we'll see how things go as we move forward. I mean, I know there's some other elements around deploying services, and you know, we're still waiting to see what that might look like as they start to exercise that a little bit more. But,
do you think we just need more publicity, or it'll just take time for everybody to catch on how to use 988?
Well, I think, you know, 988 is recording an uptick in their call volume. So I think it's okay. The intent is working. People are accessing that line more more often. Just the transfers from their line to our line, we haven't seen a lot of that. And, you know, I didn't anticipate too much based on their data, which, you know, says a very small percentage of those that they manage on those call lines turn into some deployable safety related deployment. So, you know, we really didn't anticipate there being a huge influx to our crisis line. So the good news is people are using it. It's easy to remember, and it's easy for folks to get access to a trained counselor to work through any difficulties they might be experiencing.
Thank you, Paul. Thank you. Well, actually, we're doing fairly well time-wise. My clock says what we have, it's 10 minutes to 2, and we go to 2:15. So this would be a time for any other committees that would like to be sharing things that you're working on, or any questions or concerns about committees, other ad hocs. All right.
Tim?
Yes.
Tim, I'm just wondering if Emmy could update us on the bylaws.
Yeah, Emmy, what's going on? Why are you holding us up?
I know you're joking, Tim.
It's not what I was saying.
I know.
I know you're joking because Tim Doty and I just talked about those bylaws not very long ago, and I think that we were waiting on approval of the language suggested by County Council for the grievances. So that's the only outstanding piece, and it was something you guys needed to be okay with. County Council had recommended it. You guys need to be okay with it.
Okay, Tim, you and I need to have coffee and make the decision.
The ball's in our court. Yeah, okay, that's what I was wondering if I always wonder if there's something somebody's waiting for me to do.
All right, thank you, Tim. Any other? Okay, so I just want to say this about committees. We need our SUD committee going, particularly since we have a new staff person coming in. And it's not an easy committee to run, but it's really, really important. So I want to invite all the board members to think about that, and also asking other people to be on that. SUD is substance use disorders, and also involves co-occurring. And that committee would be nice to get going again. So I just had a couple of things that I wanted to talk about, and that is we have a new person that's applied to be on the board. We were at maximum of 15. At the executive committee, we just clearly noticed that Tracy Connor, after all of her different contexts, is no longer on the board. It's kind of an automatic process because of lack of participation. That is in the bylaws. I also want to say is that no desire for us to do that. And we have things like leaves of absence or excuses. We want to be really flexible, but it's just kind of an automatic thing. So that we'll be interviewing Jacob Rosen soon, and just in order to get him, to bring him before you as a candidate for the board.
Hey, Tim, regarding that, I did contact her and left a message to just find out for sure of what she was. She didn't even call back. So
yeah,
we did what we could.
That's right. I just wanted everybody to reassure them. Thank you, Tim. So the other thing, Emmy let me know that we can start doing in-person meetings soon. And they would be at the professional building there. Is that F and 5th? I think that's the location. Emmy?
Yeah, that's the corner.
When we did it in person, we did it over at 720 Wood. And so the other thing about this room, it's the best room that's able to make us, help us do a meeting that includes Zoom. And so there are logistics and talking about that and dealing with that. Executive committee for October will talk about it. And it would be nice if we can get that set up. People know there, can come, perhaps by the November meeting, perhaps sooner. But a lot of communication needs to happen to make that happen. I want to urge everyone. This is the way we ran the board forever and ever before the pandemic. And the value of being in the same room is high. It's a high value thing, but that's where we are, and we'll see where we go with it. I want to keep you informed about that. And I guess the other thing is I just wanted to put on our agenda care court updates on a regular basis. And I guess I wanted to say something else is that the Navigation Center, which is really out of the larger DHHS the program development, the response among the board was very positive about all that's going on there. And I think it would be nice to have just an ongoing, perhaps it would come from Connie, where that's going. And I know she's worked hard for years to get that going. So again, that's important to us. That's an update that I think would be helpful for us all. Let me see. Oh, the other thing is the MHSA presentation that Oliver had to go to another meeting. It will be putting in November. He's new and trying to figure that out. And that is that is a time where we give our comments, our recommendations, our review of what it's a 3-year time frame. This is kind of the major time for us as a community to make suggestions, to review and look at that. I think it's important that we do that, that you can get that online. If there's desire for more to understand it better, it is a difficult thing to understand, but it is important. It funds many of our programs. So that could be on November, and I think that's what we want to try to do. So let me talk a little bit about our upcoming presentations. The October is going to be from Eureka Police, the CSET program, which many of us are eager to hear about. And so that will be on the presentation plan for the October. November was going to be an update on the AOT. Perhaps we need to look at that if we get regular reports from you, Jack. We don't need a more specialized or a full presentation on it. We'll bring that up. So the QI presentation, Paul, we had talked about doing that, but October and November are kind of taken, and December we don't meet. So it seems like, Paul, again, you're part of the executive committee, we may need to move that back to January. Is that going to be untimely? Because I know it's an important report and we need to hear it. Is January going to be too late?
No, I think that's fine. We've got some audits coming up, by EQRO and DHCS already scheduled. So pushing it into 2023 would be just fine.
And it's an important thing for the whole board and the public to know what is involved and why, and its intention, and how it affects our program. That whole
absolutely
thing.
And to Debbie's earlier question about data, I mean, those are the overarching reports, I think, that are good for the community to get, the board to get.
Okay, thank you, Paul. So that's pretty much what I wanted to say. We have a lot of good presentations we can be making, and executive board is kind of balancing when someone can do it and what our priorities are. So please talk to me so that we can, if you have anything you want to bring forward as a presentation. I guess that's what I wanted to see. I see 2 hands up. Tim?
Yeah, quick question for Joe. How many board members do we currently have?
14.
13? 14. Oh, 14. Okay, so I just want to say this, I guess at this point, largely for Jeremy's benefit. For quite a long time, we have our board has expressed an interest in reserving 2 seats for transition age youth. We have consistently wanted to have their voice represented on this board. We just had a discussion regarding the bylaws, whether that should be reserved, and what we've come up with so far is not to reserve them, in part because they haven't been knocking on our door. But we've had it over long term. We've had haven't had enough board members. Now we're getting up to 14. Another person can be interviewed. I really don't know what to say other than I really would like to see some of those folks on this board. And I mean, I appreciate other people are applying, but if they're going to be represented and have a voice on this board, they've got to apply and get on the board. And so I don't know, Jeremy, if they're not interested, that's fine. But if there's anything that we can do in terms of talking to them, we did make a pretty large effort to try to hear them and do what we could to accommodate them. And if there's anything more we can do in terms of talking with them, I'm certainly willing, but I sure would like to see some folks, applying.
Feedback, Jeremy?
Yeah, I can certainly bring that back to Sonia and to our HCTC staff to see if there are additional things that can be done, or we can explore to possibly engage youth to apply to be a part of the board. And I can bring that back to our next executive committee meeting to see if there are any ideas or thoughts from Sonia and from the HCTC staff.
That's right. If we got 14 now, we're interviewing somebody, probably within the next couple of weeks. I mean, that would be 15, which doesn't preclude them from joining at a future time. I think we just need to have them interested. And we can go beyond 15 if the Board of Supervisors approves it. And my guess is that they would if we had transition age youth who are interested.
Thank you. That's a good thing maybe for the executive committee to bring that up, to recommend that the Board of Supes increase the number. And yeah, it is a good problem to have, to be so full. But as I recall, I don't know if you were going to say this, Laura, but Oscar was someone that you were trying to get involved. So I'll move on and give you some time to address that if you want to. Thank you, Tim. Are you ready to have the next person speak?
Yes, my hand is going down.
Good. Good. Hey, Katie Wilson, a little bit of time here.
Awesome. I just wanted to propose several topics for possible presentations to the board in the future. One is, I think it would be really useful for us to know more about how their electronic health record at County Mental Health works. And when I say that, I mean specifically what data they can report and record and run reports on what different things, because that would be very useful for both the QI stuff and the NHSA stuff. As everyone knows, my feeling is that we can't adequately assess those programs unless we actually have data. And it might be super cool for us to learn a little bit about how that works with Avatar, or if they're changing EHRs. And then my second thing, I think it would be really interesting and useful would be to potentially have jail mental health either be a regular item or be discussed more frequently. In particular, there's a bunch of issues that come up a lot that I know I would be curious about updates on. I won't elaborate here unless you want me to, but I think that given that, the most severely mentally ill patients in Humboldt County are in jail. So I think that would be a very significant, group for us to be learning about what treatment they're receiving. All right, thank you. I'll see you guys next time.
Thank you. Thank you, Katie. Laura, I see your hand up.
Yep, I just wanted to comment on, I go to the JJDP PC or whatever it is, and have reached out to Sonia quite often to try to find Tay to be involved. So I'm pretty, and I go to those meetings so that I can try and poach young people for our board. But just also to let you know, Oscar is Tay. He qualifies for Tay. So we have one person, just FYI.
That's right. Thank you. Thank you for your work in that area. So we're kind of at the end, but we have things that we call unfinished business that we thought we were going to deal with but put off, and then other business items that we need to look at in the future. So I'm just looking at the board. Do you have some things, any comments about those things? Yes, Laura.
Medical director, hospital director, Paul, you know, I haven't asked you that in several months. Don't want you to forget.
Okay, so that's unfinished business, and we, my understanding of Robert's Rules of Order, then we put that as on the agenda item as an unfinished business until we get an answer, you know. And so I will, Joe, why don't you just write that in our minutes for unfinished business, medical director at Semper Virens, and how that's going.
What answer do you want, Tim?
I want to know whether, I think, Laura, what do you want to know about the status of that, how it's going?
Yep.
We got Emmy right there.
And we have Paul right there.
And
I mean, Paul usually.
Yeah, we have enough time for 4 or 5 minutes on this, Emmy, and then Paul, or vice versa.
Well, we're still recruiting, and active recruitment for both of those positions. And we're also exploring contracting with an organization that could help us find qualified individuals for those positions. So we're developing a contract now, and hopefully that will bring us some prospective applicants. And so that's what's new.
How about our current contractor?
We're not looking.
It's Emmy.
So we're not looking to, yeah, we're not looking to have a medical director as a contractor. We're looking to have a medical director as an employee. So this other contract that Paul's referencing is to help us with recruitment for a person that we hire directly.
Okay.
And just to be really clear, Laura, it is not going to fall off our radar. That's a critical position for us to fill.
I know. I just feel like I just want to keep asking about it. And yeah, thanks.
All right. Thank you. I'm just curious. In corporate world, they call it a headhunter. I don't like that term. It reminds me of, well, I don't want to say anymore. But it seems to me that recruitment for the county in general, it needs to special emphasis on it, and trying to find out what are the things we can do in hiring people that may not involve being in a larger community or a higher salary. And I would like to hear some discussions on that. It just seems to me it's a huge issue in terms of all staff, but there are some critical people like a medical director. So I don't want to spend a lot of time on that, but I think that would be something I would like to hear is how are you in DHSS? What is your recruiting process, and how might it be enhanced or more effective? So I see another hand from Tim Ash.
Yeah, I was just wondering if there's any kind of a timeline as far as these recruiters, when they think they could have candidates, and how long it would take to go through the hiring process to have somebody on board. And the reason I ask that is it's already taken quite a while. If it's going to take a lot longer while, maybe we could get some help from our current contractors to tide us over.
I'll just say we have a number of strategies that we're using to cover those tasks in the meantime. And right, it's a process both of contracting with them, but then also of them actually doing the recruitment. I just want to remind this group, though, that this is a statewide problem. Like, many counties are struggling filling positions, including the medical director position. And we've done lots of outreach and strategizing and collaboration around how to best get, somebody into our position. So I definitely hear what you're saying, Tim, and we can have more conversation about.
Yeah, okay, we understand, at least I do understand.
For sure, and I feel like we are pretty.
I know you were going to say you're pretty smart. Was that it you're going to say, Emmy?
I was going to say I'm super smart, and so you should just trust that. Just kidding.
Oh, okay.
I was going to say, I'm just kidding. I was going to say we're actively working to
I know.
I know you know.
I know. All right, we really are at the end of the meeting, and one thing I wanted to say about in-person meeting. One of the things that bothers me about Zoom meetings is that we can do texting together. We can eat our lunch. We can take phone calls. We can do other things than paying attention. It's a lot harder to do that when you're in the room and we can say, you're calling your wife or spouse or something like that. So, and I know that's one of the things people like about a Zoom meeting, but and it could be a challenge to getting everybody in person, but having us there together, paying attention, and also being able to talk in the hallway or out in the parking lot, was a lot of good things about. So that's my last comment. We have time for one more comment. We have 1 minute.
Did Katie have a question and lowered her hand?
No, I just had those suggestions, so I'm all good.
Okay, Alyssa, you have 90 seconds.
But what about weird people like me who aren't really great in person? Like, this is wonderful. I get to be weird. I get to turn off my video camera and be strange and just sit here and watch everybody and not worry about everybody watching me. It's fantastic. And now you want us to go in person? Oh, this is terrible.
Oh, he's talking about hybrid, right?
It's a hybrid meeting, but you won't be able to partake of our snacks,
Oh, snacks?
Oh. You're going to provide them, Tim?
I will buy donuts or bagels or scones or whatever Laura wants.
Veggie tray?
Veggie tray. Okay. All right. Thank you, everybody. I so appreciate working with you all. Take care. Goodbye. The meeting is adjourned.
Bye-bye.
Bye-bye.